بارتس أن أكون معكم النهاردة في السيمبوزيوم الخاص بالانترستو، وهيكون عنواننا Time is Essential. The heart failure is a major public health problem. It affects the quality of life. About 76% of patients struggle to perform their daily activities, and 63% of patients reported symptoms that are consistent with depression. It is the major cause of hospitalization in developed countries. Heart failure is the primary cause of hospitalization in patients aged more than 65 years. And about 44% of patients will be re-hospitalized at least once. About the mortality, 50% of patients will die within 5 years of the diagnosis of heart failure. What about the incidence of heart failure in Egypt? The prevalence of heart failure in Egypt, prevalence of heart failure is approximately 1 to 2% of the adult population in developed countries, rising to 10% or more among people 70 years of age. In Egypt, there is about 2 million cases of Egyptian heart failure. In 2015, clinical characteristics and management of hospitalized and ambulatory patients with heart failure results from ESCC heart failure long-term registry. The Egyptian cohort showed that. In the median age of presentation of Egyptian patients was much earlier than other countries participating in the registry, 57 versus 67. And those patients who are 70 years or age or more comprised a minority in our population. بالتالي الage كان أقل من developed countries، وعلى العكس من إن الماجورتي of patients اللي كانوا فوق سن ال70 في مصر كان عدد قليل فوق سن ال70. البرسنت of patients hospitalized with heart failure in Egypt, الacute decompensation بيمثل 44% من الكيسز of heart failure، وبالتالي the majority are acutely decompensated heart failure. What about treatments at hospital discharge and in outpatients? Oral treatments recommended by guidelines like ACE inhibitor or ARBs, beta blockers and MRA were well prescribed in both types of patients. What about the paradigm heart failure? This is a prospective comparison of ARNI with ACE inhibitors to determine the impact on global mortality and morbidity in heart failure. And it is first published in September 2014 in the New England Journal of Medicine. The paradigm heart failure included more than 8,000 of patients with chronic heart failure to test the effect of Entresto versus ACE inhibitors. The mortality benefit is overall about 20% relative risk reduction, with number needed to treat is 21, and this is a great number. There's a 20% risk reduction of cardiovascular death or the first heart failure hospitalization, with 20% risk reduction for cardiovascular deaths and 16% risk reduction of death from any cause, with 20% risk reduction for sudden cardiac death and a 21% reduction in death due to worsening of the heart failure. What about hospitalization benefits? Overall, about 20%, with number needed to treat 21. There's 20% risk reduction of cardiovascular death or first heart failure hospitalization, as we mentioned. 21 reduction for the first heart failure hospitalization, and 23% fewer admissions for heart failure, with 18% fewer stays in intensive care, and 38% lower rate for 30 days readmission. So all parameters for hospitalization, whether the mortality result or the first incidence or the number of admissions or in need to stay in intensive care, with overall readmissions are reduced using ARNI versus the enalapril. The treatment with Entresto provides sustainable improvement of patients' quality of life. The treatment with Entresto improves patient quality of life, including heart failure symptoms and physical limitations, as measured based on the Kansas quality of life. The effect of Entresto on quality of life is sustained up to 36 months, Over the same time period, patients treated with enalapril experienced a quality of life decline. In patients with heart failure with reduced ejection fraction, interest was significantly improved nearly all cases compared with enalapril, with the largest responses in household chores and sexual relationships. And this is the effect of Entresto versus enalapril. What about the change of guidelines? First of all, the statement of guidelines in 2016 in the American and European guidelines, they all recommend the use of Entresto for the treatment of HFrEF. In the American, they recommend use of sacubitril valsartan or S inhibitors or ARBs for patients with HFrEF. Recommend sacubitril valsartan in conjugation with evidence-based beta blockers and MRAs in patients with chronic symptomatic HFrEF with NIHA functional class 2 or 3 who tolerate an S inhibitor or ARB. While in ESCC, they recommend replacing an S inhibitor or ARP with sacubitril valsartan in ambulatory patients with HFrEF who are symptomatic despite optimal treatment with an S inhibitor and beta blocker and MRA. The breakthrough medication finally proved superiority over traditional run to activate the heart, activate life, and when you see symptoms, it's time for Entresto. In 2017, Novartis company made the impossible is possible Entresto into the Egyptian market. The initiation of sacubitril and valsartan in hemodynamically stabilized heart failure patients results of a randomized transition study 2018, also another study is pioneer heart failure, acute decrease of initially after acute onset heart failure event in hospital or shortly after discharge was visible and overall well tolerated. This is according to the new studies with relative risk reduction significantly in the primary endpoint, and they achieve and maintain the doses of 100 and 200 milligram after 2 weeks of intervention, leading to week 10 with achieved and maintained any dose of sacubitril valsartan for at least 2 weeks. What about the permanently discontinued due to adverse effects? There's no significant effect. The pioneer heart failure show hospitalized patients for acute decompensated heart failure with ejection fraction 40% or less within the last 6 months, with pro-PNB more than 1,600 or PNB more than 400. First patient stabilized while hospitalized. What you mean by stabilization? This means that systolic blood pressure is at least 100 in the prior 6 hours with no symptomatic hypotension, no increase in the IV diuretics or no use of IV vasodilators in the prior 6 hours, and no IV intros in the prior 24 hours. Stabilizations means to achieve this criteria. And what is the results of pioneer heart failure? Interest to reconfirm superiority again versus S inhibitor in hospitalized heart failure patients. There is a 46% relative risk reduction between the combination of sacubitril valsartan versus enalapril, with a great number of NNT to be 13. So exploratory series clinical composite endpoints was driven by the reduction in the risk of death and heart failure rehospitalizations. How did pioneer heart failure and the transition affected guidelines recommendations for interest? The consensus recommendation regarding use of Entresto, initiation of Entresto rather than an ACE inhibitor or ARB may be considered for patients hospitalized with new onset heart failure or decompensated chronic heart failure to reduce the short-term risk of adverse events and to simplify management by avoiding the need to titrate ACE inhibitor first and then switch to Entresto. Because these patients are already at high risk of events, there is no need to check plasma concentrations of natriuretic peptides prior to initiating Entresto. In the ambulatory setting, the guidance remains mostly unchanged. However, the paper states that Entresto is safe in HFrEF. Its activity is similar to ACE inhibitors or ARB naive patients, and thus its initiation may be considered also in these patients. So the transition study and the change in the consensus treatment for Entresto is an essential intervention for heart failure patient. How does Entresto work? First, it reverses cardiac remodeling. In the left ventricular ejection fraction, there's 25% of subjects experienced an left ventricular ejection fraction increase of about 13% or more at 12 months of use, with a reduction in the left ventricular and the diastolic volume index, and a reduction also in left ventricle and systolic volume from the baseline to 12 months, and all were highly significant improvement. Second, increase it decrease the left volume index, and it show improvement in the E over E dash ratio from the baseline to 12 months, and all p-value was highly significant in proof heart failure. What about the subgroups of interest? Reverse cardiac remodeling was comparable in each subgroup of interest. Even patient with new onset of heart failure with ACE inhibitor or ARP naive, and NP less than in paradigm inclusion criteria, and in patients not reaching the target dose. All B waves were highly significant except were noted. Rapid and sustained improvement in the census quality. The overall summary score shows that following initiation of sacubitril valsartan, the improvement in census questionnaire scores occurred early within 2 weeks and were statistically significant over a 12 months follow-up. The secondary endpoints show change in the cardiac structure from the baseline to 12 weeks by treatment. This is from Evaluate Heart Failure. There is a change in left ventricle in the diastolic volume, left ventricle in the systolic volume, and the left atrial volume index. They all are significantly. So the positioning of interest for heart failure in patients with reduced ejection fraction. This paper confirms interest to a new standard of care in place of ACE inhibitor among patients with HFrEF. The anticipated aggregate treatments effects of early comprehensive disease modifying pharmacological therapy are substantial and support the combination use of ARNI plus beta blocker plus MRA and SGL2 inhibitors as a new therapeutic standard, and this is from the AHA 2020 from few weeks ago. When to use interest with your heart failure patient, the pioneer heart failure followed by extension, serious clinical composite endpoint, the open label phase from week 8 to 12 show that there's a sustained benefit from use of interest and superiority of sacubitril valsartan over time. The time now is for Entresto to every heart failure patients. Entresto is the only medication which proved superiority over RAS blockade. Entresto is recommended by ESCC and Heart Failure Association consensus as a first-line therapy. Entresto now is fully reimbursed in the health insurance. Novartis launched the heart care program to support out of pocket patients. Entresto is available in all private health insurance companies. And thank you very much.